So first talk is by Dr. Dinesh Bhurani. So I would request Dr. Rayaz Ahmed, moderator of this session, to introduce the speaker as well as the panelist and to start the session.
Thank you, Shinto. Thanks for giving me this opportunity. So always good to be associated with the hematology seminars, especially from the South. So nice to see all the, we have once again come to discuss the hematology updates here. So for me, the role is very easy to moderate this session of multiple myeloma. The speaker of this session is Dr. Dinesh Bhurani. He is my senior colleague in Rajiv Gandhi Cancer Institutes. Dr. Bhurani doesn't need any introduction, I think so. He's the first, one of the first hematologists from India. He's the first DM. And he's at present Director Hemato-Oncology Services in Rajiv Gandhi Cancer Institute. And he has started the transplant program in the Rajiv Gandhi Cancer Institute, and it has taken to almost everything we can do in the hemato-oncology we are doing, and especially with the thalassemia program taking in a big way, thanks to Dr. Dinesh. So I'd like to invite Dr. Dinesh Bhurani to start the topic on multiple myeloma. This will be around, talk will be of 30 minutes, and later we will have a panel discussion. And the panelist will be Dr. Anshul Gupta. He is a associate professor, SGPGI. Dr. Hita Babu, she is the associate professor from Medical College, Kozhikode, and the Dr. Shajiv PM, also senior consultant from Kozhikode. So over to Dr. Bhurani for the talk. Thanks.
Am I audible?
Yes, sir.
Yes, sir, you are audible.
Thanks, Riyaz. I'm thankful to Dr. Shinto. I had a chance to work with Dr. Shinto. He's a very good hematologist and transplanter. I think he's going to start his batting. So congratulations to him. I think I've been given a very big topic is multiple myeloma. So I thought I should finish in 5 hours rather than in 30 minutes. Let's discuss a myeloma in 30 minutes. Can I request Shinto to get the slides up, if possible? I don't know whether Vikram is there or not. On Shinto, after first my photo with in parallel to Dr. Vikram was in DM exam in 2001. And second time, Shinto had a courage to put my photo parallel to Vikram in brochure. With this, I start myeloma. Next slide, please. This is one of the major hematological malignancies. If you count other cancers, is 1% of all cancers. Is approximately 10% of all our hematological malignancies. Is a cancer of elderly, but we see many younger patients. This data is from Western world. What we have, we don't have a firm data, but probably the diagnostic age in our country is 10 years, 1 decade earlier than the Western world. The major morbidity is a bone disease, followed by renal failure and infections. So other clinical manifestations are mainly anemia, hypercalcemia, renal failure, and increased risk of infection. Because it can present in a varied way, there is a typical triad of pentaid. Most of the time the diagnosis gets delayed, and that's the major cause of morbidity, and sometimes is a cause of mortality also. In the last few decades, we have known this, all the patients evolve from an asymptomatic pre-malignant stage. So the people who are diagnosed to have a myeloma today, they have a preceding few years, probably a decade of low-lying monoclonal protein. Next slide, please. These are the plasma. This is a busy slide. I don't want you to see the right side. The left side, the names have been given. So these are the various plasma cell dyscrasias, which includes monoclonal gammopathy of unknown significance. These are non-IgM, then IgM, and then light chain AMGUS. Then there is a smoldering myeloma, multiple myeloma, solitary plasmacytoma, and then there's a solitary plasmacytoma with minimal marrow involvement. So there are various different plasma cell dyscrasias have been described. I'll be restricting myself to the multiple myeloma. Next slide, please. When we diagnose a myeloma, previously we were knowing is a crab. Unless you have any defining event, we never used to call this as a myeloma. It can be a MGUS, it can be a smoldering, but to define it as a myeloma, you needed something. But now there are two criteria. Both the criteria must be made. We need to have a clonal plasma cells more than 10% or 10% in any of the places, including the marrow, or you need one of them, one or more of this. So CRAB, we know hypercalcemia, renal insufficiency, anemia, and bone lesions. But even if you don't have this CRAB or the defining events, the last few years research have shown if you have a certain, if you qualify with the certain parameters, if you don't have any events and if you don't treat it, and within 2 years, there's very high likely to have a significant morbidity because of the organ damage. So they also have been included as a part of a myeloma. They should, and the recommendation is to start treatment rather than waiting for them. So if you have a clonal plasma cell percentage more than 60%, it's called SLIM basically. If the involved uninvolved ratio is more than 100% for the free light chain assay, or more than one focal lesion on the MRI, and the size of the lesion should be more than 5 mm. Next slide, please. This shows you this is what the likelihood of so you the smoldering myeloma and what are the chances of progressing. So the very high risk group, which we showed, has become a part of the myeloma because of the research has shown there is a very high likely to have an organ damage if not been treated early. Next slide, please. Symptoms, anemia. The problem is if you have say isolated few things, anemia, the major cause of delay is probably low index of suspicion. Considering this is a rare disease and the symptomatology is more frequent with the other diseases, the diagnosis often gets delayed. And because many of the we have not been trained in the way, prediction or suspicion about myeloma is low. So anemia, because the iron deficiency is so common, the vitamin deficiencies are so common, we rarely think aplastic as a part, the anemia being a part of the multiple myeloma. So anemia is the most common. Bone pains, we can have 1,000 regions for bone pain. So the suspicion is low for the myeloma. Increased creatinine in half of the patients. Fatigue and generalized weakness is a very vague symptom. Hypercalcemia and the weight loss. So because of this varied presentation and the common symptoms, our training has not been into the suspicion of myeloma and the rarity of the disease, probably the diagnosis is delayed. Next slide, please. This is demographic data Dr. Kyle had collected over the years, 1,027 patients, and this is the age. So median was 66. This is Western data. Unfortunately, we don't have the Indian data, and this is a distribution. So if we say we don't have it, myeloma in younger age group, so you can still have a myeloma in younger age group. The frequency is lesser. More we grow up, the chances are lesser. Next slide, please. The chances are more. If you see a radiological findings in the same group, mostly these are from the X-rays because this collection is from the previous follow-up. Lytic lesions in 66% of the patients, and you can have a negative skeletal survey in 20% of the patients. Next slide, please. How do we stratify? So I think the genetics plays an important role. The FISH for various translocations and deletions is common to predict it. So the myeloma is divided into standard risk and high risk. And high risk features will include our 414, 1416, 1420, 17p deletion, 1q gain, and 1p deletion. So there are various the genetic acquired changes have been identified. The other side shows you that the chances of surviving is lesser with the each. So these are defining events, and that leads to the important prognostic information. Next slide, please. Staging is by initially we had only the international staging system, which included albumin and beta 2 microglobulin. Many of the senior physicians will be knowing Dury-Selman staging system, but there's no more the accepted system. The biochemical parameters were the defining for the staging. So and then there are cytogenetic features and LDH. So if you don't have any high-risk cytogenetics, normal LDH, and you have a normal albumin and beta 2 microglobulin is less than 3.5, you are a stage 1. And stage 3, if you have anything of these abnormal, the combination or this thing can lead to the stage 3. And if you're not into the stage 3, in between is a stage 2. The 5-year survival significantly goes down from stage 1 to stage 3, from a 5-year survival of 80% to 40%, depends on which stage you are diagnosed. Next slide, please. Initial treatment, if you were diagnosed to have a myeloma prior to the 2000, the majority of the treatments were alkylating agents with the steroids. The transplant, I had joined hematology in that era, so you treat it with the VAD or melphalan, prednisolone, and then the transplant was taking shape on that. So this is the number of patients, the percentage of patients had taken the treatment till 2000. Next slide, please. And this was an outcome in that paper by Dr. Kyle. So there was the median survival was 4 years, 3 years, less than 3 years, in fact. And there was no significant difference between whether you're below 70 or above 70. So the prognosis was not so good with these alkylators and the steroids. Next slide, please. What has changed in the last 2 decades? We have a multiple novel agents, and we don't have a multiple novel agents. We have an exciting the pipeline ahead, which we know in the next few years. So there are 15 approved novel agents in myeloma in the last few years, and many more to come. So what I showed you, the alkylators and steroids are not there in this. So there are the flood of new way to treat it. And how do we sequence it? So I think there's an intense research is going on. When you have so many things, how to sequence them as a first line, second line, and third line. As we know, the myeloma is not a curable disease. Next slide, please. So we have IMiDs. We don't have a 1 IMiD. We have 3 IMiDs. We have a proteasome inhibitors. We have anthracyclines, alkylators, steroids, the many other different mechanism of action drugs, monoclonal antibodies, and CAR T cells. So we have a spectrum of the way we treat it. Commonly we were treating till now combination of proteasome inhibitor, IMiD, and steroid upfront, followed by transplant if you are transplant eligible, and then going for the maintenance with one of these novel agents. Next slide, please. I'm sorry, I have taken many of my slides. I have stolen many of slides from CCO. I cannot make that good slide, but the way of presentation is probably mine, my original. So the myeloma is not a sprint. You're not going to cure it. It's an incurable disease. It keeps relapsing. The aim is to make the first remission longer. So the first remission is longer. The subsequent remission, the remission periods will be shorter. So and to increase the overall survival, we need to have a sequence of therapies, and potentially we have to think of a cure at some stage with the novel drugs. Next slide, please. How do we treat it? The new myeloma or a smoldering myeloma, which requires a treatment. Any myeloma defining events, which I showed you, it has to be treated as a myeloma. If it is no myeloma defining, there's a smoldering myeloma. If even the smoldering myeloma, if it is a high risk, the recommendations, there is a lot of research going on whether we should treat it earlier rather than waiting them to turn into the myeloma. That's the area of research, and the intermediate and low risk smoldering myeloma needs to be observed. Next slide, please. Newly diagnosed, we divide them whether you are a transplant candidate or not transplant candidate. 65 to below 70 or below 65 with the fit patients are considered to be transplant eligible, and the people who are the comorbidities or the because of age, they may be transplant ineligible. If you are transplant eligible, you need a 3-drug or 4-drug combination. 3-drug most commonly used worldwide is a bortezomib, proteasome inhibitor, lenalidomide, IMiD, and dexamethasone. If there are contraindications of using it or the difference in the pattern of the practice, the lenalidomide can be replaced with a thalidomide or cyclophosphamide. Daratumab is coming in. There are a recommendation. I'll be coming to this. This should be followed by transplant and followed by maintenance. I'll come to that. What should be the maintenance? Some patients you can delay the transplant. I'll be discussing. So if you are transplant eligible, 3-drug combination, 4 to 6 cycles, followed by transplant. And there is a question of upfront transplant or delaying the transplant. If you are not a transplant eligible, still there is the drug combination is same, VRD. The daratumab, there is more mature data into the transplant eligible patients, whether combining a daratumab with lenalidomide and dexamethasone or a 4-drug combination, which included a VMP, have been approved in non-transplant candidates. Next slide, please. The similar kind of guidelines are from Europe. The previous one was from US. And if you see the VRD or a DARA VTD has been recommended as a upfront first option, followed by transplant and lenalidomide. So more or less, there is a consensus probably using a 3 or 4-drug induction, followed by transplant and then followed by maintenance. Next slide, please. We'll be talking about transplant eligible patients. Next slide, please. There are a few important issues which needs to be discussed, whether it needs to be a 3-drug combination or is a 4-drug combination. Do we need to do a frontline transplant, or is it delayed? You can delay the transplant. We definitely have 2 groups, whether the both should be treated in the same way or whether we should treat them differently. So if you have a high-risk disease, whether you need to have a more aggressive strategy, and then it should be followed by maintenance, whether you need a 1-drug maintenance or the 2-drug maintenance, and then how long the maintenance should be. So these are the important issues which we keep discussing in myeloma. Next slide, please. So triplet or quadruplet, I think the quadruplet is coming in. We have data, and there are more trials. The phase 3 trials are happening. We have a phase 2 data. Next slide, please. It does make a difference. So DARA VRD versus VRD or DARA VTD or VTD makes a difference. Whether everyone should be treated with a quadruplet, even if it is approved or European Union approved happens, it's not approved yet, but if it happens, whether we should also be doing it the same way, I have my own thoughts on that. Next slide, please. This is a cost effectiveness. Daratumab is a monoclonal antibody against CD38. So we know the CD38 is expressed on the plasma cells, and daratumab has been very effectively, it's been shown in various trials, been very effective against it. So rather than using 3 drugs, you add on a daratumab, but the daratumab is very costly. Not majority of the people cannot afford in India. So I'm not talking about India. These are the data from the Western world. The frontiers in pharmacology, the conclusion was the quality of, there's a certain numbers, the DARA VMP was not as cost-effective regimen compared to the VMP. So it's not cost-effective. If you see quality of life comparison, it's not cost-effective. Another publication in JCO, the using daratumab in the first-line setting for transplant-ineligible patients may not be cost-effective under current pricing. Delaying daratumab until subsequent lines of therapy may be a reasonable strategy to limit the healthcare cost without significantly compromising clinical outcomes. Mature overall survival data are necessary to more fully evaluate and cost effectiveness of the setting. So progression-free survival is increased, but we don't have a data on the overall survival. The drug is very expensive. So I would say, even though it may be approved by FDA and other things, considering we have to have an out-of-pocket financial system, we can delay the daratumab rather than using 4 drugs. In a high-risk patients, if the patient is affordable, then 4-drug therapy. Otherwise, we can delay the daratumab for the first relapse. Next slide, please. Daratumab is not without the side effects. So there are various trials. I have pulled out the data from one of the trials. The pneumonia is increased in comparison to the whatever comparative arm is. So daratumab, it looks safer. We are not able to figure it out. We are not able to attribute it to daratumab. But if you see the randomized trials, the incidence of pneumonia is higher with daratumab in comparison to the comparative arm. Next slide, please. So it's not without. Many times we keep asking questions whether we need to do a transplant. Now I have shown you so many drugs. If we do all the drugs upfront and avoid a transplant, everyone is scared of transplant, and transplant has a toxicity. So I agree with the toxicity. Next slide, please. This is a trial was conducted, so RVD, then lenalidomide maintenance. The second arm had a transplant, and then going for the maintenance. Next slide, please. And this published this data in oral presentation in 2020. This is a mature data. The median progression-free survival was significantly favorable for the transplant in comparison to the non-transplant arm. There was a 30% reduction in the risk of progression or death in the patients receiving transplant. So even though we have a newer drugs, unless we have some mature or the more data coming in, I don't think the transplant is out. We have a newer drugs, but the transplant still plays a role. It deepens the response and prolongs the progression-free survival. Next slide, please. Considering the cost of the newer drugs, say the daratumab, I think that transplant has become cheaper. So previously we used to have that the cost, it is not cost effective. Considering the cost of the newer drugs, probably it is more cost effective than any other the newer coming drugs like a daratumab or the monoclonal antibodies or CAR T cell. Whether we can delay the transplant. So there is enough data to show it. If you don't do a transplant and delay the transplant for the first relapse, probably you don't affect the survival. But our Indian scenario, not many people opt for the transplant. So the number of people going for the transplants are anyway low. If you delay it and the people who are eligible for transplant, the very low numbers goes on the transplant with the subsequent relapses. So I think they are more acceptable. The transplant is more acceptable when you say you do induction therapy, transplant, and maintenance. More people are accepting it rather than if you delay it. So the practical purpose is, and patient is in a best health when he's done the induction therapy. My personal preference will be for upfront, but there is enough data if you want to delay it. I cannot argue with you whether we cannot delay the transplant. Next slide, please. Role of tandem transplant. So we have people don't want to have one transplant. We are talking about the 2 transplants. There is a data that high-risk patients may benefit with a tandem transplant. The aim of treatment for the high risk is we need to have a more aggressive therapy, and we want to make them MRD negative. So if you have made a high risk with the MRD negative and the sustained MRD, probably you are changing their spectrum of prolonging their survival and changing the spectrum of the disease. So there definitely is a role of tandem transplant. Some people who can afford it and are willing to go, we should offer a tandem transplant for high-risk patients. Next slide, please. Then comes to the maintenance. I think this issue has been probably solved. In between, there is an issue of a consolidation. Most of the trials includes 2 cycles of consolidation using the same chemotherapy post-transplant, 2 to 4 cycles more as a consolidation. All the trials include at least two consolidation. But if you see guidelines, they do not recommend yet for the consolidation. So still, this is an open area of debate. The maintenance is settled. If you're a standard risk, a single agent, or if you're a high risk with a IMiD and proteasome inhibitor, and if you are a standard risk, single agent. How long to continue? Many people cannot tolerate the lenalidomide for longer time, so many land up stopping it. but someone can tolerate it. There is a data to continue till the progression or at least for 3 years. So how long to continue is also open area. And now the daratumumab coming in, there is some data for the daratumumab maintenance alone or daratumumab along with the lenalidomide or with some other combinations will be there. But so far, the standard risk single agent, high risk dual agent, the high risk should be continued to maintain the response, the standard risk at least for a few years or till the tolerance. Next slide, please. We'll talk about the transplant ineligible patient. Next slide, please. What are the important issues? As I said, the issues of 3 drugs or 4 drugs, whether we should give the daratumumab, the issue is same. I think we don't have to discuss it differently. We definitely had to be worried about the frailty. We should not be treating everyone with the VRD. Someone who cannot tolerate a VRD, we had to slow down. So the frailty score or some judgment of the tolerance should be there. The adverse side effects becomes important with the age. So someone who is not transplant ineligible, we should be worried about the side effects, and we should be able to manage the adverse events. And whether we should be a fixed duration or till the progression, that also we need to discuss. Next slide, please. This is a frailty score. The same regimen does not drive a same benefit if the patient is frail. So not the same cocktail, the same intensity should be given to the frail patients. I think the age and the comorbidities and the frailty should be important in discussing the upfront therapy for myeloma. Next slide, please. We'll go to the relapse. I'll take only a few minutes for the relapse. Next slide, please. The myeloma is not a one disease. It's a highly complex, and there are a lot of genetic and clonal evaluation happens. There has been a lot of progress in the last few decades, risk stratification, knowing the clonal heterogeneity. There are a lot of genetic the things may not be bad at the diagnosis, will get worse at the time of relapse. And the patient may not be fit enough. There will be residual side effects from the previous therapy. So there's a lot of things which may not be at the upfront therapy and be relevant into the time of relapse. Long-term outcomes for the immune exhaustion, infection complications, myelosuppression, you can have end organ damage, you can have the extramedullary disease. So the relapse is not the same as at the time of diagnosis for majority of the patient. Next slide, please. What are the issues? Timing of the relapse. Someone had a good quality of life, prolonged remission, probably can go back to the same regimen. He's still sensitive to the same regimen, and he's in a fit position. Hello, am I audible?
We can hear you, Dinesh.
Shinto, am I audible?
Yes, sir, you are audible.
We can hear you. We can hear you.
Shinto?
Yeah, we can hear you, sir.
Shinto?
Yeah.
We can hear you.
We can hear you.
Am I audible?
Yes, yes.
Okay. So the selection of regimen will be depending on the many of the things, how aggressive is the relapse and what is the performance status. Next slide, please. So sometimes you have a biochemical relapse, sometimes you have so someone who is with a high risk disease, any progression, anything, we need to achieve MRD, and when you relapse, you don't have to treat MRD, but if you're relapsing, you have a clear evidence of, because of the high risk, we need to be more aggressive with the treatment. And someone has come with the symptoms or organ damage, definitely needs to be treated. Next slide, please. How do you say? So it's a triple therapy, as we had the same principle of triple therapy in the beginning, at least 2 new drugs. So if you can put in 2 new drugs, which the patient has not been exposed or had a prolonged gap in between, consider transplant ineligible patients. Someone who has not taken a transplant at the front, I'll strongly recommend a transplant at first relapse. Considering is very cost effective, is considering it is very effective, and we need to have all the therapies in the lifetime. So why to leave the melphalan, high dose melphalan in between? Someone who is still transplant eligible and has relapsed can go for the transplant. We should strongly consider a transplant. Daratumumab, I would not go for the daratumab for upfront at the moment unless we have some cost reductions in the standard risk group upfront. Probably I'll definitely consider the first relapse. Someone has a 7th relapse and we try a daratumab. I don't think the daratumab is going to work. So the 4th or 5th relapse, if you're going to use a daratumab and then you say the daratumab is not working, it's not fair. Someone who can afford it should be at the first relapse rather than to prevent a subsequent relapse, rather than we go for the 3rd or 4th or 5th line as a daratumab. Next slide, please. This is the algorithm for, so whether you are refractory to lenalidomide or not refractory, the triple combination and daratumab and the transplant, these are the things we should discuss at the time of relapse. Next slide, please. New things are happening in myeloma. So we very exciting era. We have many antigens on the cancer cell, and there are many ways we can target it. So this is one of the cancer cell is showing, and this is one of the target is most prominent is the BCMA. And this is on the cancer cell. So there are various ways you can target it. So you can have antibody drug conjugate. So we have one antibody drug conjugate. You can have a bispecific antibody, so which brings the T cells to the close to the cancer cells, and the T cells kills to the cancer cell. Bispecific T engagers or bispecific antibodies, or there are you can modify, you can genetically modify the patient's own CAR T cells, the T cells, send it to the lab, make some genetic changes, bringing that to fight to the cancer cells. So the CAR T cells and bispecific, we have a full talk on the CAR T cells. So Dr. Majil is going to talk about the CAR T cells. So, and it's not a one antigen, we have it on the myeloma cells. We have a multiple targets. You can target a dual targets rather than targeting a single target. You can have a dual target. So a lot of exciting things are happening in the myeloma field in the next few years. And they're not, next slide, please. They have been, and another important part in the future, one is that these targeting antigens with the T cells and NK cells. The second is treating upfront and making the patients MRD negative. So bringing the disease burden to the minimal residual, below the detectable level. So very sensitive methods to detect the disease. Previously, we were satisfied with the CR, no abnormal proteins visible. Then we said, no, we want to see a free light chain as acid to be normalized. Now we are going more deeper, the molecular markers, whether we can make using an upfront heavy therapy, making a patient's MRD negative and prolonging the progression-free survival. So I think the future lies between the reducing using the most potent combination upfront and making the people MRD negative. Next slide, please. And by that, we are probably talking about the functional cure. So these are the antibody drug conjugate, CAR T cell, and bispecific. I'm not going through this. These are the differences between them, advantages and disadvantages. Next slide, please. They're very effective. You see, they have been used in a multiply treated lines. There are multiple CAR T cells are available, and they're very effective. The progression-free survival is still not good enough, but it's very impressive. It is not good enough. Next slide, please. And there are a lot of improvements around the corner. This is a summary of bispecific antibodies, and they also are very effective. They're being used in a relapse setting. Now, many of the trials are coming to the front line, or to the second line and third line, and then to the first line. So many things are happening into the myeloma era. Next slide, please. What I'm trying to say, we are also there. I mean, we have the trials coming to India. We also have got a trial for the newly diagnosed myeloma patient who is post-transplant and has an MRD positive. So by using a bispecific antibody, whether we can make that person MRD negative and prolong the progression-free survival, ultimately translate into the overall survival. I'm excited that we don't get many trials in India, but we have a few trials coming in with the bispecific antibodies. And I'm excited because it's coming to my institute too. Next slide, please. And then this is in the same antibody along with the various combination, whether the only antibody, whether the combination with the daratumab and the other chemotherapies makes a difference into the relapse and refractory setting. So these newer drugs are making a way to the earlier lines, and we also get a pie of knowing upfront, knowing earlier how they are behaving. Next slide, please. To summary, I have tried to make it more as palatable as possible. There are significant delays in the diagnosis. We need to have a suspicion for that. So the orthopedician, nephrologist, physicians, everyone has to be more aware of the way we suspect and diagnose them. Myeloma is still an incurable disease. So we haven't we haven't cured a myeloma. We have started talking about the functional cure in few of the patients. So someone has a sustained and negative MRD, whether they are functionally cured, whether especially the elderly, whether they have a similar kind of overall survival in comparison to the general population. There's a significant progress in the treatment algorithms in last decade. We need to have our own tailored algorithms. So daratumab should be used upfront. We are out of pocket system. So what shall we do? Whether using that at the first relapse or second relapse, does it make a difference? So rather than you not using upfront, using at first relapse, does it change the outcome? So we need to have our own tailored algorithm. Many more options, very exciting period ahead. We need a clinical trials in India. We get a very few trials. So we need to have more trials. With this, I will stop and I'm open to the question answers. Thank you.
Thank you, Dr. Bhurani. So will I ask our panelists to take up the questions to the speaker? Dr. Anshul, Dr.
Very nice presentation, sir. It was really, you have very beautifully concise the whole topic of multiple myeloma in 30 minutes. You try to do justice to this topic. And especially for all the beginners as well as for hematologists, it was really a great presentation. So my first question to you is, in your practice, you routinely started getting cytogenetics done in all the myeloma patients, or you have now you are still just not doing routinely in all your patients? What is your protocol?
I think everyone should have a FISH test done. You can, there are many labs and you can get it done into the various affordable. You can explore the way to get the price down, because it's a very important marker to identify a high risk or a standard risk. If someone is high risk, you can prognosticate and you can justify the cost of this thing by telling the prognosis. So I think wherever we are in India, we should do a FISH for myeloma.
Yeah.
Someone who doesn't have a money, is a rickshaw puller, you don't have a money for even buying a lenalidomide and dexamethasone, probably you can skip it. But the majority should have the FISH test done.
Yeah. So that's one of the major, in many of the government institutes, that's a problem, because majority of patients don't afford getting that done, and usually we have to start treatment many times with just empirically. We are using a triplet regimen, but still we sometimes.
So I agree. The kind of practice I'm sitting, it probably I feel is essential, but the kind of practice you are sitting is not possible. So somewhere between the possible and essentiality, we have to compromise.
Dr. Hita and Dr. Shafiz, any questions from the speaker? Please, can they ask it?
Okay, thank you, sir. Sir. Hello, sir.
Yeah, please.
You're audible.
I'm audible. Thank you, sir. Sir, thank you for that very wonderful presentation. I just wanted to know, what is your approach to plasma cell leukemia, sir? What regimen and you will use?
Plasma cell leukemia is a bad disease and it's highly variable. So whether, I mean, to use a DARA VRD or whether you want to go a DT pace, someone can tolerate a DT pace with daratumumab, probably that will be the way to go. So it depends tolerability, and I don't know whether there is any trial to say DARA VTD or the DT pace versus DARA VRD. I'm not aware of whether they both are equal, but treat it aggressively. Whichever way you go, treat it aggressively.
Okay, thank you, sir.
And followed by the tandem transplant if possible, followed by maintenance and do the things. So yes.
Sir, and there is one query in the chat box regarding high risk smoldering multiple myeloma.
They're still into the, so the defining myeloma, we should treat it. High risk smoldering myeloma, I think is still in a trial phase. So I'm not sure whether it's become a FDA approved or whether it's become a part of a guideline, whether we should treat it. But if you see Vincent Rajkumar's this thing that recommends to treat it with RD or lenalidomide. So the smart recommendation shows as to be treated.
Okay, thank you, sir.
Sir, how often you do a PET-CT in myeloma?
PET-CT is very cheap. So you should not be, someone who can afford it, you should do a low-dose CT, PET-CT or MRI, the whole body MRI. I don't see the whole body MRI is available in majority of the places. So it becomes a PET-CT or low-dose CT. But someone who cannot afford it, has a few lytic lesions, you can get away with a skeletal survey also. Depending on the finances. The kind of practice I'm sitting it, people can afford it, and we do a PET-CT most of the time.
Sir, I have one more query. If the patient is on relapsed myeloma, he is on POM DEXA for 1 year, and he has completed 1 year, he is in biochemical CR, and should we continue as a POM maintenance? Any data for POM maintenance in this setting?
I'm not aware of any specific POM data, but considering it's a relapse setting, should be continued.
Okay, sir. Thank you, sir.
So I have one query. In a patient who has come with renal failure, advanced renal failure, who's dialysis dependent, and we started him on VCD regimen, and suppose after 2 or 3 cycles, he starts developing a severe neuropathy, peripheral neuropathy, then what's your approach of changing the regimen? So a renal failure is there, he's dialysis dependent, as along with it, he has developed neuropathy to bortezomib. So how do you juggle around with the therapy?
Renal failure is a one area where if you have a significant free light chain or there is a cast nephropathy, whether you will someone can afford a daratumumab with the VCD, you should consider, you want to bring to get the renal function better. So someone who can afford it, probably you would consider a daratumumab. People can differ on this. So depends if someone is dialysis dependent and neuropathy. If you have a good response, you can continue with the cyclophosphamide dexamethasone or pomalidomide cyclophosphamide dexamethasone. You can change, depends on the response. Someone who has not responded, then you will have a problem. Someone had a creatinine come down and significantly, you can use a low dose of lenalidomide also. Thalidomide is one of the options. So you can change it to Thaldex. But the neuropathy is there, probably the thalidomide will not be a good option. I think there is a discussion among themselves, or it is just a question.
Sure, sir. So thank you, sir. So one question to you. Role of tandem transplant, are we out of the tandem transplant has gone, and the role of dual transplant means when should we promote, or you should recommend, I should say, tandem transplant, and when should we recommending dual transplant?
When you say dual transplant, you are saying auto?
Means second transplant. I mean to say the second transplant. Patient has done auto transplant, had been in a CR for 2 years, 3 years.
Someone who has a high risk disease is not MRD negative after one transplant, I think should be considered for tandem transplant. We had to make the high risk disease MRD negative. So if you want to prolong the survival for high risk, if you can make him MRD negative with a maximum therapy, including a tandem transplant, should be done. Someone had a prolonged effect with the first transplant, should be offered a second transplant. So if you had a more than, I think there are recommendations more than 24 to 36 months, then you should recommend a second transplant. But sure. This will go down. Your requirement for the second transplant will be more because you have a newer drug, you have a more effective drug. So if someone had a more prolonged benefit with the transplant, probably they are more likely to go for the second transplant. So more the newer drugs coming into the upfront or the relapse setting, your second transplant probably will go further down.
Thank you, sir. So that will be all from my side. Over to organizers, Dr. Shinto.
Thank you, Raya sir. Thank you, Bhurani sir, for that nice talk, and thank you, Raya sir, and all the panelists.